in English. So I will go slow, and hopefully it will be easy to understand my New Yorkese. It is a pleasure to be here as a partner with Medical Sur, and the relationship they have with Mayo Clinic is very deep and rich, and it really is a mutually beneficial relationship that both institutions share the knowledge together to make our patient care more successful and more humane. So I'd like to start off with a simple phrase from one of Dr. Servan's mentors on the topic of epilepsy. And the risk of dying is high when people have seizures, even infrequent, obviously when they're not controlled. And it is low when they have none. And that comes from Dr. Michael Sperling. Now, Dr. Sperling is an epileptologist, but it emphasizes the importance of getting control of epilepsy. And the best control is the cure, so we strive for that when possible. In new technologies for treating epilepsy, I want to talk about a few things. The first is talking about laser ablation. It's a technology that's very new. I'm not sure how well known it is in Mexico. It is new in the United States, and it is really being used a lot, but there have not been a lot of randomized controlled trials to see the exact extent of effectiveness. But it's a fascinating technology, and I'd like to spend a little bit of time with you on that. So I'd like to spend some time talking about, well, this is the bad part of the egg, right? I hope no one is going to take offense, but that's the cholesterol. What's the egg white? Palabras, por favor. Protein, right? People get egg whites because they like the protein. But you can see here that the temperature change didn't necessarily get hot enough to cook the yolk, but clearly the protein is very sensitive to temperature change. At this point, the protein has a structure, and enzymes have a structure that allow them to work because they fit into a receptor. If you change the shape of the molecular bonds and the conformation of a protein, it doesn't fit into the receptors, and that's why the enzymes don't work anymore. So that's called coagulation, or it's called denaturation at the chemistry level. What you don't have, so this is what happens in the brain. If you heat the brain up with a coagulation probe or a light energy from a laser, you want to do this. What you don't need to do is that, okay? So that's not what we do with the laser in the brain. So again, we have to realize now that we have a way to get the temperature up. If we monitor the temperature, we can prevent it from getting too hot. We don't want to burn the brain, but we know we have a target to reach where we have confidence that the cells will be dead. So, getting back to our patients who have epilepsy, uncontrolled epilepsy, trying to find a way to minimally invasively get their hippocampus that's causing the epilepsy to die. We find some of the technologies we have, and so we want to, activate or inactivate the hippocampus. We want to kill the structure in the brain and the temporal lobe that causes the seizures. We know we can put a probe there with high accuracy using stereotaxis. We know we want to heat the proteins to coagulate them or denature them. We don't need to burn or vaporize the brain. And then how do we monitor this? How do we do this without causing too much damage? So again, we're going to go back to the new technology of magnetic resonance thermometry and this temperature-sensitive MR imaging, which will allow us to follow along as we make a lesion, and we follow the temperature change. Now, it's not just a temperature change because there are two variables that will determine cell death. It's no different than in stroke, as an example. It's the severity of the injury and the duration of the injury that will determine, in particular, in neurologic tissue, the extent of damage or death. So it's not just how hot you're going to make the brain, because we know at 60 degrees it will all stop. But if at 55 degrees, how long does it need to be at that temperature for the cells to die as well? So we want to use both the variables of temperature and time to monitor the lesion that we're creating. You want to model, we want to model this using a mathematical model of damage, because in the MRI scan, you're not watching the anatomy, you're just watching the temperature. So you need to design a computer program that is predictive of how much damage is occurring. It's not going to be the actual because again, the MRI is now giving you temperature, not anatomy. This model, how do you know that your model is accurate? So how do you? So this is a real case. It's a little bit faster, just the way it plays in the computer. This doesn't occur this fast in real time. But you can see in an axial view or a cross-sectional view and a side view or sagittal view, you see the probe that has been placed from the back of the head into the temporal lobe. And what happens is you place the catheter and you turn the laser on, and what you're watching here is the thermometry. Why the heat moves back is you're pulling the laser catheter back after each treatment. So you treat a little bit in the front of the hippocampus and amygdala, you pull it back, you treat a little bit farther back, pull it back, a little farther back. And so this is real-time monitoring. So you're watching the treatments occur, you're watching the temperature. What this is a special computer that is predicting the amount of damage that's actually occurring. So the computer model uses the two variables of time and temperature. It knows how hot it is, measure how long it's hot at any one point in the brain, for how long, and it will then produce a damage map that predicts cell death. And at the end of the treatment, after you added them all up, you summate, this is your final damage, or this is the prediction of how much tissue you've damaged. Okay? And if it's the hippocampus and it's causing seizures, it would be ideal if this would be the way that the treatment goes. So this is a real case. This is a simple case. Actually, it's a tumor, but it shows you the catheter that's placed into the temporal lobe. There's a small tumor in the front. This was the treatment model, and then this was the validation. This was a real MRI, not a temperature MRI, that shows you with contrast the extent of damage. The point of this is if you look and see how closely this matches the prediction, it gives you a high degree of confidence that you know how your treatment is going. And when I was talking about how do we know how the brain temperature is and how hot to make it to do the effectiveness of a treatment. And here's the side view, same thing. You see the probe in the temporal lobe. You see the extent of damage that's predicted. And then you see the post-operative scan that shows you how well the correlation is between the predicted and the actual. So we know with stereotaxis, we can have a very high degree of accuracy. We place the probe in the temporal lobe. And this is the system that we happen to use at Mayo Clinic in Arizona. It's called a Visualace system from Medtronic. It consists of a small anchor or a bolt that goes into the skull. You can see a very small incision here, the size of a fingernail. There's a catheter that has saline that goes in and cools the laser fiber optic. And here is the laser fiber that goes to a box with the which sits out in the control area. The patient is in a typical stereotactic head frame after placement of the catheter. And you can see the accuracy of placement into the hippocampus using the image-guided stereotaxis. Here is a treatment of temporal lobe epilepsy with a hippocampal. Here is the immediate post-treatment real-time measurement. It's interesting to note that was damaged compared to the immediate treatment size as the hippocampus dissolved. So laser ablation is a very new technology. There are currently studies ongoing to measure more critically the effectiveness. We know it works sometimes. We know it works not all the time. The real question is, what is the best estimate that we can tell patients for informed consent? We need to tell them the changes that may occur with this treatment versus other treatments, the side effects and complications. But the big advantages over our conventional technology is that it is minimally invasive, very small incision, minimal hair shave if that's important to you, very little pain, very little risk of infection, and patients can go home after this the next day, and then the benefit does start immediately. So again, the effectiveness, I comment, is promising because there is no objective level 1 evidence of how good it is. We know it does work. We know it does not work all the time. So at that point, depending upon how much time we have, it depends. I should move on to the next technology, or are we good? Más o menos? Okay, I'll keep going. Pull me off the stage. Okay. That was an example where we knew that the hippocampus was sick. and we use laser ablation technology to damage that for that type of epilepsy. But what are the other types of epilepsy technology that we can use? And so here's a history, a patient example, a 35-year-old woman who has a long-standing history of epilepsy. It's not clear why. There's never been any good control. She's had everything done, and we really don't know what's happening. So the imaging is normal. All the non-invasive tests are normal. She's had many video EEGs that have been documenting her seizures. And so here we put people on the hot seat. Dr. Casino is sitting in the front row here. What does this show? Exactly. So Dr. Casino mentioned you cannot see localization, lateralization. You really, it's occurring. So much artifact you can't tell what's happening. So I will say that there's been a lot of medications tried for this specific patient, 8 different medications in 14 different combinations. She's tried drugs, and more drugs. She's had as many non-invasive tests as we can give her, and we really have not had anything that's really been effective. So what do we do next? So we know that there are invasive options. This is not new technology. This is old technology. You can imagine how much brain is exposed to put it on the surface of the brain on the temporal lobe. Again, in between, this is a big operation. So for those of you, this is the exposure that you need for an operation similar to that. For those neuroanatomy, this is the frontal lobe on the left side. This below here is the temporal lobe. But for Dr. Devalle and myself, because now the frontal lobe is up here, it's upside down, and temporal lobe is here. That's the way neurosurgeons the patient. Anyhow, the newer technology, stereo EEG, is interesting because in and of itself, stereo EEG is not terribly new, but there are some nuances of new technology that make stereo EEG much more effective. And as you can see, what I'm referring to here with stereo EEG is multiple small, very gentle electrodes are placed in different areas of the brain. Multiple small openings are made, holes, but it covers a large region of brain without having to remove a large portion of bone or without having to expose a lot of the skull. This is a patient who, by the way, was bald before surgery, had no hair, but this is what it is like. And I think I'll show you a short video of what the surgery, let's see here. Oh, maybe it won't play. Maybe we'll skip the video. Okay, so EEG over a craniotomy, a big operation to expose the brain, is this. This is a real-time graph of a week's worth of a hospital admission for a patient who had all those electrodes placed in the brain. This is a scale measuring their pain control. This is how much pain they have. So Dr. Casino, again, I'm going to make Dr. Casino on the hot seat. How many patients with craniotomy have zero pain after surgery for a week? None. Exactly. It hurts to open up your skull. In one episode of pain, I wasn't sure if this was a migraine or something, but you can see in general, pain control with stereo EEG is exquisitely good. So from a patient-centered perspective, it's wonderful. Now, what is the information that we get with stereo EEG? And not necessarily new. You can get areas that are deep in the brain that are much more difficult to reach than you can get with the standard electrodes on the surface of the brain. And image guidance is important. Let's see if this one plays. So just again, scrolling through an MRI, you can see multiple at various levels inside the head at different areas of the brain to a greater degree than you can get from just a surface exposure. Now, how can I get out of here? Mm-hmm. Okay, so here's the new component of stereo EEG, where we now have a high degree of accuracy with image guidance again. So MRI with contrast. The complication rate from stereo EEG and from all epilepsy surgery is related to two things: the number of electrodes that you place inside the head and the length that you keep them there. The number of electrodes, the risk is because you will hit one of the blood vessels that's on the surface of the brain, so you want to make sure you avoid them. Before MRI, before image guidance, you really had to do your best job of trying to be lucky. It's hard to be lucky at the time. But the rate of hemorrhage, now that we have image guidance, we can place the catheters and avoid all the important blood vessels in the brain. So from the standpoint of effectiveness, the technology gives us increased safety of SEEG. The second thing that image guidance gives us is confirmation of placement. So if I want to see that I'm at or below, in this case, the hippocampus, I know exactly where my electrode is. I'm right in the middle of the hippocampus here. I know I'm in the superior aspect of the temporal lobe here. The confirmation increases your level of accuracy. So when you're trying to understand what part of the brain you're actually monitoring, you now know with this image guidance and this model that combines CT and MRI with your stereo EEG. You can also get good modeling of where your electrodes are placed to understand the topography. If you do surgery, you want to see what the surface of the brain looks like where you're going in. And what we like to use is something called a hybrid implant strategy. So you know with those SEEG electrodes, you're only picking up small points that you're recording from deep in the brain. So how do you know exactly what and how much to remove? Well, you combine your target, a general area, and you can use then more conventional methods, which is instead of a big craniotomy, you have a small opening, a small grid, less risk, and that you identify the area where the seizure starts, where the area of the seizure spreads, and that means the area that should be removed. Awake surgery is nothing new in neurosurgery. See if the audio plays. Oh, actually, it's doing surgery with a patient of the epilepsy's focus from their brain as you're doing surgery. That's not new. But if we get back to SEEG, we can get to areas that are not accessible easily with open surgery, such as the posterior insula. This is an example of an SEEG case where deep in the insula, on the left side of her brain, of a patient with seizures but no focal lesion. And she does not want to have surgery to remove that part of the brain because of the risk to language. So what other options do we have from technology? So I'll use this as a simple, quick example of my last few slides. This is something called a responsive neurostimulator. It has a small battery, it has a computer chip, and it can get implanted with electrodes deep into the brain, in this case in the posterior and anterior insula areas of the brain. What does this do? And this is what it looks like during the surgical implantation. Again, a battery, a computer chip with a programmer, and it actually does responsive stimulation. This is a device that is like a built-in EEG monitor. It will record the patient's brain waves. It's a built-in EEG or seizure detector. It tries to pick up when a patient has a seizure. And then it's a built-in treatment model because then it can provide a small current or counter shock, if you will, depolarization to the area where the seizure starts in the attempt to suppress or stop the seizure. And that's called a brain responsive stimulation or responsive neurostimulator. The device is called the RNS. And again, how it works. It's placed into a place of the brain where you think the seizures are starting from. So you have to use your SEEG, you define your focus optimally. These are the electrodes that detect the seizure. It goes back to the computer then generates a charge, and that takes care of inactivating the seizure at the place that it starts. Again, I could go on about outcomes, but I think it's time I should end. And if you have questions or more want to know about the RNS system, I do have lots of more slides. But at this point, I think I've run over my time. The red light's blinking, so thank you very much.